You're listening to Just Medicine, an equity in healthcare podcast created by medical students in British Columbia.
Hello, everyone. I'm Yi Zhang. I'm a fourth-year medical student, and I'm one of the hosts of the Just Medicine podcast. And here today, we have Dr. Alec Yu, who is an internal medicine resident physician at UBC, who is passionate about supporting those who experience poverty, homelessness, and chronic disease, together with his longtime supervisor, Dr. Anita Palapu, and many other collaborators. They have established new programs at St. Paul's Hospital, including a specialized discharge pathway, a transitional housing unit, and a peer navigator service for patients who experience homelessness. And today that will be our main topic. So let's dive into it. So, Alec, I think with our listeners, a lot of us are quite junior in our training, and we might not actually have like this kind of foundation of what homelessness means. So, do you mind kind of explaining that to us?
Of course, it's my pleasure. And thank you so much, first off, for having me. And I do want to acknowledge that I am calling in and zooming in from the unceded ancestral territories of the Musqueam, Squamish, and Tsleil-Waututh peoples. I do want to acknowledge that there's so much intersectionality between indigeneity and homelessness. Not that I'm an expert in the area, but I think it's something for us to continually reflect on how the legacy of colonialism and systemic racism has really generated a disproportionate amount of homelessness and poverty and suffering amongst Indigenous peoples. But to your question specifically, the definition of homelessness is not something that's necessarily internationally agreed on. However, there is an organization from a number of prominent social institutions in Canada that have formed a group called the Canadian Observatory on Homelessness. They kind of keep track of facts and figures and statistics on homelessness in Canada and feature certain projects that are going on across the country. And they've defined homelessness as a condition that someone is in when they do not have stable, permanent, and appropriate housing. And I want to really stress just how broad that definition is. It's not just someone who is using the emergency shelter system or sleeping on the street. It's someone that may have at the moment a roof over their heads, but it has no prospect of permanence. It is inappropriate for their physical or social needs, or it has no aspect of stability. And so people that are in this definition, there have been strong associations through multiple prospective and retrospective studies that it is associated with increased hospitalizations, increased mortality, and increased morbidity in a variety of different ways. And I think that when we see our patients and see people with potential housing instability, it's always important to ask and to screen, because there are oftentimes folks that may not look quote unquote traditionally unhoused or homeless, but really are going through a period or perhaps prolonged period of housing instability that's really relevant for both their health and social outcomes.
It's really lovely that you've given us this very broad definition of homelessness, because I think a lot of the patients we see don't necessarily, fit into like a conventional, traditional paradigm. So kind of like with that, being said, are there any kind of screening tools or questions that are your go-tos in those circumstances?
For sure. I ask every single patient that I see the question, what is your current living situation like? And I ask that to them whether or not they come into the Emerge in like a 3-piece suit and tie and like a Louis Vuitton suitcase, or if they come in looking very obviously that they've been sleeping on the street for quite some time. And the reason being is that you learn a lot from that question, no matter what sort of social demographic the patient is from. When they're quite affluent, sometimes you learn specific things about their housing situation and specific exposures that might be relevant. When they look just sort of completely inconspicuous, sometimes you learn that they actually have a lot of mobility problems or mobility barriers, or they have a lot of financial stress or strain that they have kept hidden from friends or their doctor or family or so on. And then, of course, when they look outwardly like they may be experiencing homelessness, you can get a better sense and opportunity to explore what kind of housing they are currently living in, what the major barriers that housing presents to their health, and go from there in terms of referring them to the right resource.
Yeah, I think that's a really lovely approach. And I think, in certain areas of medicine, we do for sure ask about people's living situations. But I think we have a tendency, I think, in other areas to perhaps not ask as much. So to have that broad question open to everyone, I think it gives them the opportunity to at least speak to it and to kind of get the help that they may need. So
Totally.
I also wanted to ask if perhaps, according to the literature, are there like defined different forms of homelessness, or is it still like quite broad in terms of the different forms?
Yeah, I think that the literature will tell you that homelessness is generally seen on a spectrum, right? And at one end of the spectrum, there are people that are currently housed, but at high risk for homelessness. And so these could be people or families that have housing that's very quite dangerously and immediately lacking in safety or stability. These can be people that are very low and fixed income seniors whose rents are going up, people who are experiencing severe mental or physical illness and unable to work and make rent payments and things like that. Then kind of further down that spectrum, we have people who are what we would define as provisionally accommodated. People who are provisionally accommodated are people that have housing, but they have no prospect of permanence built into that housing. And so people that, for example, have been evicted and are living in a motel, people that are living in a modular housing unit that has a defined time limit. Most of the modular housing units that are built here in Vancouver have a residential limit of somewhere between 12 and 24 months. Moving further on that spectrum, of course, there are people that are emergency sheltered. And so people that are accessing the day-to-day, night-to-night emergency shelter system that we have across the province. And of course, as you and the listeners probably know, there are a number of restrictions and quite stringent restrictions on what it means to keep your bed. And at the same time, there are a lot of shelters where, unfortunately, the overall living environment is unsafe for a lot of people, but particularly for perhaps women and younger children. And as a result, a lot of people actually will choose not to access the emergency shelter system and be in, I suppose, the furthest end of the spectrum, which is to be unsheltered homeless. And these are people that have chosen not to access emergency accommodation, either as a result of feeling unsafe in those environments or as a result of those environments being inaccessible to them. The shelters do have limited capacity, particularly in the winter when things get quite cold and rainy. And so if the shelters are all full, which happens unfortunately not infrequently as the rates of homelessness rise in our province, people just don't have access and need to be unsheltered.
Yeah, I think, that's like really, enlightening to hear about homelessness on a spectrum because I think we often think, is this patient, are they experiencing homelessness or are they not? So I think reframing that as a spectrum kind of gives us perhaps an opportunity to like act on a more upstream level as well. So I think that's really helpful for us.
Glad.
In terms of kind of like what you've learned from your experience and the literature as well, what are the main causes of homelessness?
Hmm. That's a great question. And I think that, the obvious answer is kind of right in front of us, right? Homelessness is the result of extreme poverty. But I think that if we were to look upstream in terms of what causes and what factors predispose someone to living a life where they are more vulnerable to homelessness and extreme poverty, I think there are a few factors that are particularly relevant here in BC and somewhat sadly so. One strong factor that we know from both the epidemiology and the research is that about a third of people who are homeless in our province grew up in the youth in care, sort of foster care or group home system. And these are oftentimes people that have experienced a great deal of trauma and violence. In fact, about a quarter of people who are homeless in our province cite on surveys that their primary initial cause of what pushed them into homelessness was some sort of violence or abuse. And over 50% of people, who are homeless in BC report a history of childhood sexual or physical abuse. And so there is, and this is not to say that there aren't fantastic people out there working in our foster and youth and care system. That's not to say that all foster families traumatize their children. That's the last thing I'm trying to say. But I think that it is something that is a strong risk factor that we know is something that is entirely outside of someone's control, but does have a huge predisposing factor to someone's social well-being in the future, and physical well-being goes right along with that. We also know here in BC that people who are above the age of 55, which is what the Canadian Observatory on Homelessness describes as a senior if they are homeless as a result of just an overall lower life expectancy amongst folks who are homeless. That group above 55 is the fastest growing age group amongst people who are homeless here in BC. And that's a result of fixed incomes not matching up to the very rapidly rising rent prices and the various ways in which landlords have found to circumvent the tenancy protections that exist in BC in order to put people through things like rent evictions and so on and so forth. And again, not to demonize all landlords, if there are fantastic landlords that take really good care of their tenants, but more and more we see that senior citizens are the fastest growing group of people who are homeless in our province. And of course, being senior on a fixed income is again not something that is in one's control. We all age and so on. I think that it would be probably remiss not to also acknowledge the fact that 2 out of every 5 people who are homeless here in BC are Indigenous, although it's only about 5 or 6% of the total population of BC who are Indigenous. And that is hugely disproportional. It is by far more disproportional than any other ethnic group that makes up individuals who are homeless. And I want to really stress here that it is clearly not indigeneity that is a predisposing factor for homelessness. In fact, being well connected to one's culture and community is a huge protective factor against extreme poverty and homelessness. And we know that from both the literature and from the lived experiences of Indigenous people in our province. But it's really the generations, the centuries of colonialism and systemic racism that have been perpetrated against people who are Indigenous that makes that the risk factor, that makes that such an unfortunately prevalent phenomenon in those communities, and is really the cause of a lot of suffering, both amongst individuals and intergenerationally.
I think, it really sounds like from what you're describing, Alec, there's like these different vulnerable populations who have unfortunately experienced homelessness as a result of kind of systemic failures, right? It's really, I think, I want to reiterate your point that, it really isn't indigeneity or, someone aging or someone having
No,
grown up in that care system that renders them homeless, but it's kind of like the accumulation of the trauma that they may have experienced that predisposes them. And I think that really speaks to the fact that I think as a system, like we need to do better, right?
absolutely.
Yeah. From your perspective, then, kind of like what can we do to actually combat homelessness on a systemic level?
Ooh, on a systemic level,
Mhm.
I think that, when we look at the broader literature over the last 20 years, there have been a number of interventions that have been tried to combat homelessness. And the ones that are very consistently the most effective are early homelessness interventions and early housing interventions. And you and your listeners may have heard of interventions like Housing First, where when someone has a number of comorbidities, be they mental health, substance use, physical health, etc., the first intervention that is prioritized for people is getting them housed. And we know that Housing First not only improves, of course, their housing status, but also improves their status socially and from a strictly health metrics perspective. It decreases their rates of admissions. It decreases their rates of emergency department visitations quite consistently. It increases their connection to primary care. And on a broader social level, it decreases their rates of recidivism and it increases their rates of job attainment long term. And so early housing interventions, I think, are things that we should strongly advocate for, in addition to early interventions across the board, right? It's extremely challenging. And I'm sure that you and your listeners who have, been through clerkship or have had time on the wards know that at some point, people are sort of chronically or become quite entrenched in street homelessness. And it becomes very difficult at that point in order to rebuild their lives and their social and physical capacity to the point where they can function independently as a member of society on their own and attain stable housing. And I think that that is more of a symptom of a system and a society that's failed them early on. We meet a lot of people, perhaps not so much in the hospital, but in more outpatient related services that have become newly homeless or have been bouncing in and out of homelessness for less than 6 months. And we know that that population, if early and appropriate and aggressive interventions are applied from a housing perspective, from a social services perspective, a case management perspective, and if they have comorbid substance use and addictions medicine perspective, that the rates of being able to lift those folks out of homelessness and prevent long-term chronic homelessness are generally quite a bit more successful than efforts towards folks that have been homeless for 3 years or more continuously. Not at all to say that we should give up or stop dedicating resources to that second population, but we know from an effectiveness standpoint that early intervention works better.
So it sounds like kind of, similar to the principles that we apply in medicine a lot of the times, right? We talk about preventative medicine, but I think it's really interesting to hear this perspective from you because, to be honest, it's the first time that I'm hearing about this early intervention as a solution. So I think our listeners will also find that it's very eye-opening.
Hmm.
In terms of direct resources, I find that for me, I struggle a lot when, a patient, I see them on the ward, they tell me they're homeless and then you want housing, but, unfortunately there's just not housing. So what kind of resources can we connect our patients with in those kinds of scenarios?
Yeah, great question. So there are a ton of resources, and I don't know if there are show notes to this podcast, but I'm happy to give you a little cheat sheet that I've made for my internal medicine residents about what resources are available provincially and in Vancouver from a housing perspective and a number of other domains. I think that if, you are an independently practicing physician, in the community, and you don't have this huge hospital system, social work and transitional services teams and stuff behind you, the one housing intervention that I think is important to know is the homelessness prevention program. That's a program that's run out of BC Housing. And it's an application, I believe it's 3 or 4 pages the last time I checked, and it can provide temporary rent supplements in addition to some discretional costs to help someone secure housing. And so this includes things, I'm sure, you've moved before, I've moved before. It's very stressful. It's very costly. Things to help people offset those costs, like storage costs or costs to get ID or costs to get transportation and things of that nature. It also provides people with a case manager, and that case manager can follow up with that individual on a week-to-week or month-to-month basis and make sure that they are connected to the broader network of resources that they might need in order to succeed in finding housing. This program is designed for, and people will qualify for it if they are at immediate risk for homelessness. And so these are people that have either become recently homeless or they are leaving hospital without stable housing, or they can include some of the risk factors that we had talked about previously, like youth transitioning out of care, people who experience severe mental illness, women who have experienced violence in their relationship, and so on. And so if you have someone in your office who sort of fits that category of at immediate risk of homelessness or has recently begun experiencing homelessness for the first time, the homelessness prevention program, I think, is a really great one-stop shop resource that you can refer them to.
Wow. Yeah, that's really amazing that I'm hearing this, interestingly for the first time. And I'll definitely link the resources in the show notes.
For sure. Thank
Because
you.
yeah, like I think we do see a lot of these folks, who are at risk and really experiencing homelessness early on in their journey.
Mhm.
And it really, yeah, it's really, actually shocking to me that I haven't like ever heard of this resource. But I think it just speaks to the importance of, what you said, that we need to act at a more upstream and earlier point to help our patients. So,
Totally. And I think part of the reality is that, a lot of our training in medical school and residency is inpatient based, right? And as an inpatient medicine provider, especially internal medicine, we see a very disproportionate amount of people who are chronically homeless and already connected to all of these resources, or at least have been in the past. And these resources have to some degree not succeeded in preventing their current state of affairs. And so I think that it's easy for students and residents going through to become somewhat, hopeless or nihilistic about the whole situation. But then you move to outpatient medicine and you see way more people in which you can provide more upstream intervention. And, realistically, from a statistics perspective, there's 3 times as many people in our province that are in the at-risk or recently homeless category than there are people who are chronically homeless, have been homeless for over 6 months. And so I think that, I just want to encourage your listeners not to be discouraged if they're doing a lot of inpatient medicine and all they see are people who are quite chronically street entrenched and so forth. Not to say that efforts to help this population are not also extremely worthwhile, but there is certainly room to use these interventions that I'm sort of talking about, perhaps more so in the outpatient setting once they get there.
thanks for sharing that. I think something else that we kind of come across as learners quite a bit as well is, the stigma that is attached to patients who are experiencing homelessness. So, how
Mhm.
can we, as medical learners, destigmatize this set of vulnerable people?
Yeah, yeah. And this is not just for learners, this is for everyone, but I think as learners, especially as medical students, you have the privilege of time, right? Generally, and I know that the hospitals are very busy and oftentimes things can feel very busy, but generally you do have a bit more time to take care of the patients that you're assigned to. And you have a bit more capacity to talk to them and to learn their story and to build a relationship with them. And I think especially for people who are labeled as frequent flyers, revolving door patients who are coming in and out of the hospital all the time for things like cellulitis or osteomyelitis or endocarditis, when their underlying diagnosis is really poverty and homelessness and substance use disorder. These people, I think they come into hospital and providers oftentimes think that there's already a plan for them, right? Like consult addiction medicine, consult CTU, antibiotics, opioid agonist therapy, and then they leave to go back to their old life. And I think that patients really internalize that narrative about themselves, that they are just this chronic patient in and out of the hospital, when in reality, as you and I both know, they are so much more than that. And I think that when people take the time to learn their story, build a relationship, that becomes that, fertile ground to develop the trust that's needed to help them make the next steps towards whatever their goals are. And once that trust is built, people are able to reach out more proactively and receive the help that may or may not be offered to them. And I think that in those situations, you can make such a profound difference in people's lives. And when people see you doing that, including, senior residents or senior attendings, you're able to sort of show them something, right? You're able to show them that that this individual that's been coming to hospital, every 3 or 4 months for their infection or whatnot, they are a full human being with a very diverse life story and experiences. You're able to sort of teach them about that patient's story and circumstances, and provide really meaningful and long-lasting, impactful care. And I think that that's something, that's definitely a way in which, as a senior resident on internal medicine, some of my medical students inspire me, and is something that I try to embody as much as I can on the wards as well.
Yeah, that's a really lovely sentiment. I really appreciate you sharing that with us, because I think, yeah, a lot of us can find, it's difficult, to see patients suffer, over and over again, and then to see them get labeled, kind of, so to speak, by the system. But I think I very much echo your sentiments, and I think a lot of patients, their lives are so challenging that it's, not going to necessarily take like one admission to get everything fixed and in order. And I think, yeah, as a medical learner, it's been like really eye-opening for me to personally shift myself away from that kind of narrative,
Mm-hmm.
where it's one where we're really empowering our patients. We're really sitting down and listening to their stories, seeing them as the human beings that they are. Because sometimes it takes, maybe 20 visits or like 30, whatever it is, right? It's not
Whatever it is,
linear.
exactly.
Yeah.
Yeah,
Mhm.
and it goes back to even something as basic as our documentation around patients, right? I think our documentation largely, like it shapes the narrative that a patient lives in. If your documentation is this person coming in with their sixth admission for, alcohol intoxication and withdrawal, from a shelter, active substance use disorder, plan is, CWA and consult addiction medicine, and then discharge home once clear. Like, that is all probably medically accurate, right? And CMPA and the college will never fault you for that. But really, if we were to change the narrative to, this is a human being experiencing unstable housing from a background of severe trauma, they might have had children that were taken away from them. They might have experienced physical or sexual assault. And as a result of those factors, they have found it extremely difficult to manage their comorbid mental and substance use related illnesses. And as a result, have found themselves in a position where they're unable to provide a stable income, experience extreme poverty, and have thus far experienced unstable housing. I think that your issues list becomes so much richer, right? How can we help this person address their trauma? Do they need a connection to an outpatient mental health team? How can we help this person address their interactions with the perhaps child protective services, right? Do they need a case manager that can advocate for them and can give them the motivation to participate in treatment programs and in, maybe a live-in treatment or residential treatment program, such that they know that a goal of reuniting with their family is possible at the end of the day. And when we change that narrative about someone, I think that we're able to better address, or at least have a chance of addressing, the root causes of why they're in over and over again.
Yeah, I think just, listening to those two different examples, it's really powerful, what our words can convey. Like, especially in the second example, I think, just as you said, that person will probably get a lot more resources just by virtue of the words that we're using. So I think I want to certainly, give our listeners a sense of hope as well. So kind of, what are some examples of success stories that you've had with patients?
Who are homeless?
Mhm. Yeah.
Let me think about this. I can think of a couple examples. I mean, I think that, to be honest, I work at St. Paul's quite a lot, and St. Paul's sees a disproportionate amount of people who are sort of chronically unstably housed and experience homelessness. And so maybe I'll give one example there, and one example that's maybe a little bit more broadly applicable. I remember, this is maybe 2 years ago or so, we had a patient who was admitted from a modular housing unit, And he was very much so a frequent flyer to the department and was admitted with a number of infections, including, cellulitis. I think he had osteomyelitis of the sacrum or something like that, and really not functioning well at all at home, even though he was in his sort of mid 40s. And if you were to look at him, you would think he's 60. He really was in really rough shape. And in the beginning of his admission, he was extremely reluctant to engage in any care, wouldn't allow the nurses to change him, wouldn't allow us to examine him. And I found that extremely strange. I think that it's uncommon that people would just entirely refuse an exam day after day. And so I made that as sort of a central issue, right? Like, why is he refusing care so much? And over the period of a couple of weeks that I had the privilege of taking care of him, we were able to build trust, and he was able to eventually tell me that the home supports that were put in place on his last discharge a few months ago, he was getting different care aids every single day, and they were sort of accessing his body for personal care. And with his particular trauma history, he felt extremely re-traumatized and violated by that experience. And so we were able to work with his home support services. I had a number of phone calls with them over time in order to set up a more consistent schedule for him of people who are taking care of him, and trying to choose people that, would be, well, I think everyone should be, but trying to choose someone who was consistent and someone that he could build trust with, and maybe, obtain consent from each day in terms of personal care. And so with that, I think that we were able to help him engage with care a bit better, give him the type and the environment of care that he needed, and be able to keep him out of hospital for much longer. This is an individual that I now sort of follow up with once in a while in an outpatient setting, but he has not needed another inpatient admission for the last 2.5 years. I think that, that's a very, to be honest, it's a very St. Paul's story. And I can think of a number of other stories. Like, for example, I was recently on cardiology back in the summer at Vancouver General, and I had admitted this older lady who, just looked like your very typical, early 80s, I think she was, lady who came in with an NSTEMI. We had cuffed her, stented her, and she was, ready to go home from our perspective. But she was really anxious about going home for some reason. And I was chatting with her one evening when I was on call, and she broke down in tears and told me that she, as a fixed income senior living in South Van, was very stressed about making her rent. And she had been working as like a cashier or a greeter or something at a grocery store on the side in order to sort of make ends meet, and was stressed every single month about her rent. And so I was able to connect her with a program called SAFER. That stands for Shelterly Aid for Elderly Renters. And that program provides people in her exact situation, fixed income, low income seniors, with rent supplements every single month so that they can age in place. And so we were able to really alleviate that stress for her and discharge her in a more sort of safe and holistic manner. And I think that that's a program that is really quite underutilized, especially amongst our older adult, lower income population, that can really be applied in both an inpatient and an outpatient setting anywhere in the province.
Yeah, I think that like your examples are very inspiring. And I think just from listening, I'm quite, inspired. And I think like the two kind of lessons I've taken away are just, being knowledgeable about the resources that exist out there, because admittedly, like, we really do not get a lot of training in medicine about all these resources that exist. And then,
Yeah.
yeah, sometimes it's interesting when you call up kind of like one of these resources, right? Like I think you kind of have this preconceived notion sometimes that, oh, all the shelter beds are full, or like there's nothing out there available for this patient. But, just in hearing your story, it's like, wow, like there is actually a lot out there that is underutilized and that we just might not have awareness of. And then I think the second kind of lesson that I've learned from just you sharing your story is that like, it's really important to just be human with these patients and to take the time to just, more so like not just treat on kind of, you know, doctor to patient level, but just human to human, right? What can we help them with? So thank you for sharing those really inspiring examples.
No,
Um,
totally. It's my pleasure.
yeah, I think kind of I want to shift the conversation a little bit because I think I hear a lot of this sentiment of kind of like not in my neighborhood, especially in Vancouver, quite a
Right.
bit.
The NIMBY or whatever, right?
Yeah,
Yeah.
I hear that a lot, and I feel like, as a medical learner and just like as the person that I am, hearing this in conversation, it's it's interesting and I want to say something about it, but it's almost like I don't really know what to say. Is there anything that we as, learners and medical professionals, is there anything that we can do to combat this kind of sentiment?
Yeah, that's really tough. I have to be honest, I have not done a lot of political advocacy in Vancouver around homelessness personally. And so I don't think that I'm probably the best person to give practical advice around this. What I will say is that, when I was, I still think of myself as growing up, but when I was growing up in Coquitlam, I grew up in East Coquitlam, and I remember that I was trying to advocate for our first transitional housing unit that was being potentially planned at the time. This was maybe about 12 years ago. And I remember showing up to city council meetings and consultation groups in Coquitlam, and there would be dozens of NIMBYs coming out. I shouldn't say, I feel like there's a negative connotation there. There are dozens of community members that felt very strongly emotionally against the building of this transitional housing unit. And all of their arguments, to be honest, were based on emotion. There were very few people that made any attempt to make an evidence-based argument. But because there were so many people relative to myself and the folks that were in favor of doing this, that our points would really be drowned out. And I think that I think that, whoever speaks the loudest and with the most passion, oftentimes if they truly outnumber people that have evidence, they sometimes win anyways, unfortunately. And so I would just encourage you, when you see a project or a cause may be vulnerable to, like unfair community backlash, that it's very important for us to do things that are maybe a bit more inconvenient or uncomfortable, like show up to these meetings, like, I know that the city has these like online forums for consultation and like online Zoom consultations about development projects. I don't know how much in-person stuff the city of Vancouver does. I just see sort of like the billboards for like online feedback forms for new developments all the time. And I think that like our voices, we can't let them be drowned out. I think that although it's certainly the inconvenient and more time consuming thing to do, the other side, so to speak, the other opinion, so to speak, is more motivated to do those inconvenient things in order to prevent important housing developments or social projects from happening. And so I think that we need to show up with just as much passion and evidence, and that can give us maybe a better shot at preventing these types of important projects from being blocked. But to be honest, that's just sort of like a subjective observation. It's not something that I can definitively cite a resource and say that this will definitely work. It's just sort of been my experience over the years.
Yeah. Okay, thanks for sharing that. Yeah, it really speaks to the importance of kind of just using our voice. And I think just as you said, sometimes it doesn't necessarily have to be as involved as like, really like actively going to all these meetings all the time, but even just speaking to our MPs and just making them like aware that there are people who support these causes, I think is important. Just in terms of kind of like what is the most rewarding thing about the work you do in helping patients struggle with homelessness? Can you speak to that?
Yeah, I think, and to to be fair, and I say this not to diminish the work that anyone does in healthcare. Everyone does extremely important work, but truly the degree of difference that you can make in someone's life, when they are struggling with numerous social barriers, and one of them being housing or extreme poverty, the degree of difference that you can make is transformative. You know, having the relationship with someone that is trustful and they they invite you into their life to start working on some of their goals together. There is nothing more transformative, I think, in someone's health than that. And you can see people really, I don't know, become animated in a new way that you can see they've not experienced for months to years, giving people the opportunity to regain skills and capacity to rebuild the life with the help of social services and yourself and the healthcare system and so on. And these people will value their relationship with you as a healthcare provider more so than I think any other patient that you're going to have during your training or your career. And I think that privilege is so special and is so unique and is so rewarding. And I hope that everyone gets to experience that during their training or so on. At the same time, you know, it's obviously not always like that. You know, it's obviously very difficult, and especially with the volume of patients in the situation that we sometimes deal with, especially a site like St. Paul's, it can get really discouraging sometimes when you are trying your best and, you know, feel perhaps emotionally exhausted by the volume of suffering and trauma that you're seeing that you're not able to change. And I think that, you know, I still do, and in the past really felt quite morally distressed by seeing all of that. And two of my important mentors, one of them being Dr. Palapu, who is the current head of medicine at UBC, but has had an extremely successful career in advocacy and research for folks who are homeless. She told me that, you know, it is still extremely valuable and important to be able to maintain someone who's experiencing all of these barriers and help them continue on their journey to improve the life that they have. You know, it doesn't need to be that that's the admission that fixes everything. That very rarely, if ever, happens. But to be able to just build enough of a bond such that you can provide them the care they need right now to go back to their lives and have a second crack at it, or a third or a 30th or a 40th, that in and of itself is still extremely valuable. And something that we as trainees, as you know, people early on, shouldn't forget and shouldn't let that discouragement fully turn us away from working with people in this population.
Yeah, wow. Thanks for sharing that. It sounds like while we certainly, you know, might get success stories, I think we kind of have to sit with the concept of like meeting patients where they're at the same time. And I think, yeah, you know, the work that you do and the work that we do, I think overall is just so important. I think certainly there are cases that are morally distressing, but I don't think it diminishes the value of the care that we provide and the fact that we can continue to build relationships with patients who are struggling with this. I guess my last question to you, I want to end off on a positive note. And I think, you know, we do talk a lot about, you know, vulnerable populations and the risk factors that patients have and all of this. But I think in my experience, and probably I'm sure in yours as well, like a lot of these patients, you know, they demonstrate such resiliency and strength. And so, you know, how have you seen this kind of like manifest in your practice?
Yeah. You know, we've been talking so much about the limitations of our system and how it oftentimes fails people that really need help from it, that, you know, maybe don't get what they need, or even worse, are traumatized by the system that they're trying to get help from, as we've seen in a number of landmark reports like In Plain Sight recently. And yet at the same time, you see people persistently reaching out for help, persistently trying, persistently doing things that take an unfathomable amount of courage. You know, someone who has failed 30, 40 times to beat their addiction or to overcome their trauma, trying for the 31st or 41st time. I cannot imagine just how much courage and perseverance and persistence it takes for that person to get out of bed every morning and say, today I'm going to try again. And you can see that across the board, that despite the incalculable odds, every glimmer of hope they're willing to take. And I think it's interesting that, these are oftentimes the patients that the healthcare system seems to dislike the most, right? These are like the most frequent flyers and so on. And yet they take every opportunity to reach out. And every time I think they deserve a fair chance to be connected with as a human being and to have their goals explored and offer whatever it is that we can offer.
Yeah. Wow. Thank you. Thank you for sharing that. No, I don't think anything that I can say can really wrap that up. Like, just, such amazing sentiments to wrap up the podcast with. And I really hope that our listeners can be imbued with a sense of hope in the care that they provide, because I think we are providing care for people who are just, so resilient and amazing and strong, despite all the challenges that they experience with the healthcare system. So yeah, again, thank you so much, Alec, for your, what you've shared today, because I think I've walked away with so many things to think about. And also, I'm really glad that you're sharing with us this list of actionable resources that we can connect our patients to.
For sure.
So thank you. Thank you again for recording.
Thanks for tuning in to Just Medicine.